So we are live. So firstly, welcome everyone. I'm Dr. Cole, and we're back here on our journey about World Diabetes Day and diabetes awareness for November 14th November 2017. So just to give you a little background on myself first, I'm a researcher here at The Ohio State University, and I have a few years of experience in diabetes and diabetic complications research. I've seen the condition from the point of view of different individuals as something that either just evokes no response to the other extreme of evoking too much fear sometimes. And all too often we'll hear definitions of diabetes as the silent killer, the number one cause of kidney disease and eye disease and heart conditions. But there's very little effort that goes into educating, guiding, or empowering individuals who either live with diabetes or have a risk of diabetes. Which is exactly why I really appreciate the work and efforts of individuals like our guest today, Dr. Sarah Hallberg, who you can see on the screen, as an individual who really brings forth knowledge as the most important weapon against diabetes. So just to give you a brief introduction, and Sarah will, I'm sure she'll hopefully come in and need it here. Sarah is an adjunct clinical assistant professor at the Indiana University of Medicine, and she is the medical director at Virta Health, also the executive director at Nutrition Coalition, and she served at the boards of the American Heart Association in the past. She wears several hats. Amongst them, she is the driver of nutrition reform, she's an author, and she is also a self-professed low-carb enthusiast and ketogenic diet lifestyle propagator, so to speak. So is there anything you'd like to add to that, Sarah? Anything I've missed out?
Well, actually, at Indiana University Health, I'm also the medical director of the medically supervised weight loss program there. So
fantastic.
You're right, I wear multiple hats, but also the same mission that I'm very passionate about, which is helping patients who struggle with diabetes. So thank you for having me.
It's an absolute pleasure and a great opportunity for us to actually hear from you. So in the interest of time, we have just 30 minutes thanks to some of the technical difficulties we were facing. So we'll jump straight into some of the questions that we would have around diabetes, which are pretty basic. To begin with, you mentioned that you're very passionate about diabetes, and I'd really love to start by asking, what is it about diabetes that you're so interested in? Why do you care so much about diabetes?
Well, so I'll tell you a little bit, about my background, and it tells you why I'm interested in this. So medicine is actually my second career. So I was an exercise physiologist and worked in weight loss as my first career. I had my master's degree in exercise physiology, and then jumped into going to medical school and spent close to a decade in primary care, dealing with diabetes, dealing with weight, but only in the setting of primary care. Right. And when Indiana University Health came to me and said, we'd like to start an obesity program, would you be interested? I jumped at the opportunity because it really brought my interest from the past, pre-medicine interest. And my pre-medicine days, when I really worked in the field of obesity, I knew that treating obesity was frustrating for providers and also for patients. And that if we were going to start a program, we needed to go back to the research, look at the evidence, what's been shown to work. So when we started the program, it started out as a low-carb program, and very quickly the focus changed from obesity to diabetes, because what we were seeing was remarkable. Patients' diabetes reversing. I mean, we were getting people off of hundreds of units of insulin. And so I looked out to say, wow, this must be what everyone is doing, right? And of course, the cricket in the silent room. We couldn't find anybody doing this anywhere. And it certainly was not in the standard of care. And I was so frustrated. And so I really took a leap at that point from being a clinician, all my practice, into being a researcher. And have now just treated so many patients with type 2 diabetes. And, I always used to say that when patients came in to see me in primary care, and they would cry about many different things. But here, when patients come in to see me and they cry, it's about one thing. And it's, why didn't anyone tell me this a long time ago? Before my heart attack, before I lost all those good years. And that is impactful for the provider. Like, how can you not be impassioned to help someone who, with that story? I want to help patients who struggle with this disease and help get them out of the vicious cycle of aggression and more medication.
That's fantastic. And that's exactly what we've just touched on in the beginning as well, that prevention and empowerment and just giving the tools to your patients really is where the secret is to dealing with this condition. So now fascinated by surely something that most people find very fascinating, which is going from your TED Talks and some of your publications. Are fats really good? Are they that good that they are particularly good for patients with type 1 and type 2 diabetes?
Yes, they are. That's the short answer. Absolutely. Yes. And now for the little bit longer answer, which is, number one, fats are good if they're whole food fats.
Right.
So I get that question all the time, what is a good fat? And that's the answer. It's a whole food fat. So, we encourage fat consumption for our patients. Right. But again, that does not include highly processed vegetable oil and soy oil. So, it doesn't matter if it's saturated fat that maybe comes from meat or from coconut oil, or if it's maybe monounsaturated fat that comes from olive oil, or even omega-6 if it's coming from seafood. But again, it just needs to be whole food based. And the reason why that is actually good, especially for patients who struggle with insulin resistance or type 2 diabetes, is that fat is the only macronutrient that won't cause insulin or blood sugar to rise.
Right.
So we have 3 macronutrients, and that is carbohydrates, protein, and fat.
Yeah.
Carbohydrates cause a big spike in both insulin and blood sugar. And protein has some spike too. But with that, it's a flat line. And of course, if there's no spike in blood sugar, remembering that the problem in type 2 diabetes is elevated blood sugar, then that is what we want to be consuming.
Fantastic. Okay, well, that is really, I think, the most concise answer we could have to this, because, again, we can get into details of your previous talks about this, but building on what you've just said, in research, you often come across the concept of lipotoxicity, that fats, surely cholesterols, are also known to have an impact on heart disease and diabetes and even pre-diabetes. So how do we differentiate between the lipids and the cholesterol and the sort of fat that you're suggesting goes into nutrition in these individuals to control their diabetes?
Yeah, so that's a great question, and I actually have kind of a two-pronged answer to it. So first of all, the concept of lipotoxicity. And you hear this a lot about people who are opposed to a low-carb, high-fat diet. And, I actually agree with them on lipotoxicity as far as a lot of health concerns are. But here's the thing. What causes fat levels in the blood to go up? Actually, it's carbohydrates. Mm-hmm. I mean, this has been incredibly well described, that increased carbohydrates cause an increase in triglycerides. But there's another step, right? So what we like to blame is saturated fat in the diet, right? We think, okay, that's going to be bad for heart disease. But actually, study after study has come out association between consumption of saturated fat and heart disease. However, there are a number of studies that show that saturated fat levels in the blood, different from consumption, right, are associated with heart disease. Right. And there have been some beautifully done feeding studies looking at this. And what they find is if you eat a lot of saturated fat, the saturated fat levels in your blood do not change. Right. But if you eat a diet high in carbohydrates, the saturated fat levels in the blood will go up. So not only are we making fat out of those carbohydrates, we are making saturated fat. So, although lipotoxicity is very likely to be a culprit in a lot of different diseases, we have to ask how it got there. And I think that the evidence for that is in the literature already. Sure. Next, we have the question of cholesterol, because this is, of course, a very common question. You know, if I eat a lot of saturated fat, won't my cholesterol go up? And actually, we are going to be submitting a paper looking specifically at this soon. So I can't really discuss our 1-year results from our large clinical trial, but I can speak to our early results that are already published on this, plus additionally what is already in the medical literature. And that is, in patients with type 2 diabetes, we're not seeing these big rises in cholesterol with a low carb, high fat, even high saturated fat diet. So, you know, what we see is triglycerides will go down, HDL, the good cholesterol, will go up. And then as far as LDL cholesterol goes, we see a few things. A mild decrease, which really surprises people, unchanged, and in a couple of studies we see a slight increase. But a slight increase in LDL-C with a large decrease in triglycerides mechanistically is what we would expect. Okay, it doesn't mean that there's any increased risk. It means with lower triglycerides, there's actually less exchange going on. So it is more important when looking at a patient with type 2 diabetes that they not make any decisions based just on LDL-C. Although consistently, as I said, it either goes down, stays the same, or rises slightly. You need to be looking at particles. So LDL-P, which looks at the number of particles, or a test called ApoB.
Right.
And with those, we don't see rises.
Right. You're right. I think it's just the fine-tuning between the fat consumption and the carbohydrate consumption. So potentially, if you just, all your calories are coming from the carbs plus the fats, maybe, that's really where the issues lie. But fine-tuning those is really where you could switch between cholesterol, or rather a cardiovascular threatening cholesterol profile versus a healthy lipid profile. That sort of brings me to another question, that in several cultures, especially in the eastern part of the world, the diet has typically always been very heavy on wheat and rice consumption. And these are also cultures that in the present day, because of modernization and in fact moving away from these diets, are beginning to diabetes. In the understanding of personalized medicine being specific to certain genetics and certain backgrounds, would you say that there is such a thing as better responders to the carb-free diet? Or do you think that this is just something that applies across the board to all individuals?
No, I think that's a really important point and a really important question, because if you look at cultures, so really, you know, kind of original diets, what you see is that humans appear to have the ability to do great and thrive on a wide variety of diets. So there are cultures who consume a high carbohydrate diet and do well. There's plenty of examples of that. There's also a number of examples of cultures where they consume a very high fat, very low carb diet. That is their diet of origin, and they do great also.
Right.
So what changes is when we bring insulin resistance into the mix.
Right.
So when we bring insulin resistance in the mix, then we shrink from this, you know, wide range of diets that are very doable to keep humans healthy, into very small amounts of dietary choices in order to promote health. Right. And that's where carb restriction becomes really critical. And as far as the cultures who ate a lot of rice in the past, one of the other things to remember is they ate, maybe percentage-wise, a significant amount of rice, but overall their consumption was not that great. In other words, their total caloric intake. So one of the big things that has changed is not only have we brought in processed foods and sugar, which are clearly implicated there, but we brought in abundance of food as well. So again, in many of these cultures where we're finding diabetes skyrocketing, we're also seeing that more and more people don't have to restrict food by necessity any longer. So it may be that rice in a small amount is okay, but once you add rice in a non-calorie restricted manner, then it becomes a problem. So lots of different ways to look at that.
Certainly, that actually does make it sound like a lot more, again, down to fine-tuning, but very interesting points as well about the overall caloric consumption and the way that's changed in the past few years in our species in general. This brings us to the keto diet concept, because that's what we've discussed in the past. Colleague Dr. Wallach here at OSU. Keto is almost an extreme form of the carb-free diet, where you try and induce ketosis, which is within a healthy range, and it's meant to improve and, in a sense, reprogram metabolism, if I understand correctly. So what are your views on the diet, and particularly its practical applications, because it seems to be such a fine line that you have to tread to maintain ketosis? So what are your comments on that?
So I utilize a ketogenic diet to treat my patients with diabetes all the time.
Right.
So I think that, you know, one of the things people refer to it as extreme, you know, as you said, people refer to it as that often. And I would actually take a little argument with that point and say, you know, it's actually just what it's not extreme, it's actually what that patient's metabolism needs. Right? So we've got a problem with their metabolism that is causing elevated blood sugar. And so we just need to restrict the carbohydrates, right? Increase the fats that aren't causing an elevation in blood sugar. So I would say rather than extreme, it's just needed in the type 2, particularly patient population. And so, you know, a ketogenic diet, it's going to be very interesting over the next, you know, 5 to 10 years, with all the research that is going on as far as the ketogenic diet goes, not just treat metabolic disease, and there's plenty of research in that arena. Right. But I think what we're going to find is that ketones are going to be used in the future to treat a wide variety of health issues. We've known and used the ketogenic diet to treat seizures and epilepsy for 100 years. And there is more and more research going on in related neurologic fields. So treating Alzheimer's, Parkinson's disease, and now we're seeing a boom in ketones as far as cancer research goes as well. So I think that while this dietary approach is definitely best for type 2 diabetes, and again, I would say is really needed in that situation, it very well may be that patients who follow this are going to get additional benefits as well. But again, you know, time will tell. The research is not completely solid in that area, but is booming right now. So it's very exciting. But again, I would also say that when patients who struggle with type 2 diabetes are following a ketogenic diet, the other big advantage there is they don't get hungry, and they find that to be much more sustainable.
I see.
You know, we hear that all the time. Oh, I could never do that, right? I could never do that. And that's the number one thing. Oh, I could never live without bread. And I always turn to someone who says that and say, spoken like someone who's never tried to live without bread. Sure. Because you actually crave what you're eating right now. And when you get it out in a week or two, surprising to everyone, but consistent, if you don't miss it. Right. And so, you know, exactly, is it just the fat? Is it the ketones? Is it a little bit of both? You know, the point is patients find it easier to sustain that.
That's fantastic. Sustainable and practical from the sound of it, which I think is the number one tendency that people imagine is not the easiest way of handling this diet. But like you're saying, it's actually easier in some ways to stick to a diet of this nature as opposed to other typical low or restrictive diets. A spin-off from that, would you expect an individual on a ketogenic diet who is a patient, in your case, for example, in your clinics, would you expect them to perpetually remain on a ketogenic diet, or would you normally suggest cycles of these? What's usually a recommended scenario here, or strategy?
Personalized, ultimately, is the quick down and dirty answer there. Okay. And so for some patients, they can be on a ketogenic diet temporarily.
Right.
They may improve or resolve, completely reverse their type 2 diabetes, and then be able to increase their carbs to some degree. Yes. You know, Other people, they may have had diabetes for a very long period of time. Their body isn't producing enough insulin, and so they have to stay on that really low carbohydrate diet to keep their diabetes reversed, their blood sugar under control. So it's very dependent person to person. And when someone is lucky enough to have, resumption of some insulin sensitivity and be able to tolerate some more carbohydrates, what we always say is, look, you may be able to take in more carbohydrates, but this will come back. The blood sugar will rise again unless you can remember some simple things about the carbohydrates you choose. So what I always tell people is that what you don't do again is you don't consume GPS, which is no grains, no potatoes, and no sugar.
I see.
So while they may be able to take in a higher total carbohydrate value through the day, those are the things that we really want to stay clear from permanently.
Right.
Because those are the things that can get you right back where you started from.
Absolutely. Absolutely. Fantastic. Well, this is a lot of very fascinating information, but if, as a novice, I'm planning a diet intervention for myself, where do you think most people who are trying to do this on their own, as opposed to going to a professional, might fail? Where might they need more support, potentially?
Well, so I think that, physicians are going to play an important role here in helping people, because I would really begin my answer here with saying caution, caution. So for a patient who has type 2 diabetes and is on medication for this, or any medication for that matter, it is critically important that they get help adjusting those medications. Everyone is surprised by just how quickly medications can be reduced when you decrease carbohydrates. And this is actually a safety concern for people on medication, especially medication like insulin or a class of diabetes medications called sulfonylureas or something called SGLT2 inhibitors. So it's really important that everyone work with a physician for help in medication adjustment. And I think we're going to see more physicians kind of taking the bull by the horns, if you will, here, and putting this into their practice. But it's something that you have to make sure that the physician you're working with knows something about, because it's very interesting. In medical school, we're all taught, right? You will agree with me, how to prescribe medications like crazy. But no one teaches us how to take them away. That's actually both an art and a science. So, I like to consider myself a de-prescribing expert. That's what I do. I know how to do it well. And so it's very important that patients approach this with caution. And again, that's one of the reasons that I work for Word Health is here to help patients with type 2 diabetes by providing them with physician support, in addition to health coach support to help them with those day-to-day dietary changes and advice. So again, I would also encourage anyone who's interested to go to www.vertahealth.com for more information there.
Just going to ask you if there's a good nutrition information and a little bit more about the ketogenic diet. Is there a good resource that you would recommend? So I'm assuming Word Health is a go-to place?
Yes, that's a good place to begin with. And, there's many sites on the internet these days that will tell you information, but it's really important that you make sure that the information that you receive is evidence-based.
Absolutely. Fantastic. That really is most of the questions covered for our conversation today. I think in terms of understanding nutrition and its extremely important value in diabetes reversal and also potentially prevention, this has been very insightful. If there's any concluding remarks you might have for people who might either be at risk of diabetes, who currently are living with diabetes, what's the one thing you would probably tell them at this stage?
I would tell them to take control. And anyone who says diabetes is progressive and there's nothing that you can do about it, type 2 diabetes, I would say, find a new provider, because we know there is evidence in the literature that that is not the case, and that we can help patients take control of the disease and get their health back. And the thing is, we can do that without just more and more prescribing, which again has been our standard of care. Yeah. That we can do this with a whole food-based approach and a focus on lifestyle. And I just, I would like to shout that from the top of the mountains to everyone, which is use food as medicine. It's something, unfortunately, we got out of the practice of doing. And if we could embrace that again, boy, would we be better off for it.
So much for the great insights, Sarah. And thank you so much for your time. I'm sure a lot of people will benefit greatly from this. Thank you so very much.
Thank you for having me.
Likewise. Thank you. Pleasure. Bye.